Excited to introduce Dr. Dashevsky, who's a clinical associate professor in the division of breast imaging at Stanford. She also serves as the director of research for breast imaging. She completed her doctorate in physiology at Oxford as a consultant. And she has numerous publications and awards internationally. She's on Society of Breast Imaging and ABR committees. And an interesting research on like 7-test MRI to evaluate pathology of resected breast specimens. She's going to talk about contrast enhanced mammography. I'm excited about because we're actually looking into implementing that here.
Thank you so much for that introduction and for everyone for coming today. Sorry for a little bit of a late start. So today I'm excited to speak to you about contrast enhanced mammography. What makes CEM especially relevant now is the growing evidence supporting its clinical application. The technological advancements, we now can do CEM guided biopsy, and also there's just increasing pressure to optimize cancer detection.
You want it darker? I can put the black on. So
Darker would be better. And also just pressure right now to optimize cancer detection in both resource-constrained environments and high-volume settings. So with CEM, we have improved breast cancer detection compared to screening mammography and screening ultrasound. It's an opportunity for improved patient care, improvements in workflow, and increased access to vascular imaging. So today I'll cover how breast imaging has evolved, how CEM performance compares to other modalities, and where it fits into the clinical workflow. Most importantly, how you can thoughtfully and successfully implement it, since it looks like that's on the horizon. So to understand where contrast enhanced mammography fits into breast imaging today, let's look at how far we've come. So in the 1960s, you can see that we had a pretty rudimentary direct exposure film mammogram. Radiologists used general purpose X-ray tubes, no breast compression, and they were direct exposure films similar to chest X-rays. The images were low in contrast, and you can see here that back near the chest wall, it appears white due to underexposure. Imaging times were long. This resulted in image blur, and there was no collimation. Shortly thereafter, zero mammogram was developed. So you can see with zero mammography, you can see that the fat appears white instead of black. This is a printing process where you use blue ink and you print it on paper, actually. So this had a wider dynamic range. You can see more tissue fat distinction, but came with lots of new problems. So increased radiation dose, the toner was inconsistent. And then also you can imagine, just if you think back to when you would print things all the time, that you would get paper jams, and this would be a huge problem. So then next came screen film mammogram. So this really took hold in the 1970s with the landmark 1973 study showing that screen mammography had tremendous benefit. Since the introduction of screen mammography in the mid-1980s, 36% fewer women die each year from breast cancer. With screen film mammogram, we started to have standard compression processes. That means that if there's a uniform compression across the breast, that allows for sharper images, a more even exposure, and decreased image time. It also introduced collimation, allowing for reduction of the radiation dose, but also improving, again, the contrast resolution. And this really laid the foundation for what we have today with full field digital mammograms and tomosynthesis. So most people come in, and when they get a mammogram, 88 to 95% of women will have a normal screening mammogram. But of course, what we're trying to detect are these small cancers. And here you can see how easy it is to detect a tiny cancer when they're surrounding fatty tissue. But of course, we all know that as breast density increases, our cancer detection rate goes down. So in a patient that has predominantly fatty breast tissue, we detect about 86% of cancers. In a patient with extremely dense breasts, we only detect about 61%. You see, some cancers here on these mammograms that you can see how hard it would be to identify it if it was in this dense breast tissue. So tomosynthesis, FDA approved in 2011, really helped for patients with dense breasts. So with tomosynthesis, we obtain multiple low-dose projections across an angle and a continuous sweep. we're able to scroll through the tissue and see underlying masses. Here I'm showing you a case where you can see architectural distortion that's not visible on the screening, the 2D screening mammogram. And differentiating overlapping tissue is also especially helpful for decreasing callbacks. So fewer women need additional imaging of benign findings. And with tomosynthesis, we see these improvements at all breast densities. So here I'm showing you on the y-axis, you have the cancers per 1,000 screens, and on the x-axis, you have the recalls per 1,000 screens. And you see at every single breast density, there is both a decrease in the number of patients recalled and an increase in the cancers detected. Cancers are also meaningful cancers. It's a 29 to 41% increase in invasive breast cancers. Now we have contrast-enhanced mammography. So contrast-enhanced mammography has been progressively integrated into clinical practice over the past decade. First approved by the FDA in 2011. But it's had a much slower uptake. Right now we have at MQSA accredited facilities, 92% of sites have tomosynthesis. Most places don't have CM or are just starting to look at CM. There are a lot of limitations to that, and we'll go over that in a little bit. So CEM, we need IV iodinated contrast, the same contrast used for CT. You obtain 2 exposures in each position, a low energy and a high energy. And both are obtained after the administration of the contrast. So what we view is a low energy standard 2D mammogram, and then the subtracted CEM image. So here's a patient with very dense breast tissue that came in for a screening mammogram, and the same patient, this is what her CM looks like. So this patient has minimal background enhancement, and there's no suspicious finding on her CPM. So a nice normal case. It's very quick. Now, here is a 55-year-old that came in for screening. She has a history of prior benign biopsies on both sides, actually, and that's why you see those biopsy clips. Much more challenging evaluation. So if we look at her mammogram obtained 3 years prior, this is called normal. And she had a CM performed immediately thereafter. And here we can see 2 areas of non-mass enhancement in the left breast. So for us, we treat these exams just like we treat thyroids for MRI. So because we bill it as a diagnostic exam, this patient was a BI-RADS 4 for both sites on the left. On the right, it was a BI-RADS 2, rather, for the clinic. So for the suspicious finding, the patient then goes to ultrasound. And so when we give a BI-RADS 4, the nice thing there is it makes it very clear cut for our team. So the person doing the ultrasound, if they don't see the finding, then it's clear to them that we've already they're going to go directly to CEM biopsy. So what is CEM indicated? So for patients that are high risk, 20% or greater lifetime risk, that are recommended for MRI, but they can't obtain it. So they can't obtain it because they have an aneurysm clip or their body habitus, or some patients are very claustrophobic or just really uncomfortable with getting an MRI. So CM is an option, but MRI is preferred in those cases. You can perform CM diagnostic evaluation, preoperative staging, treatment response, or if you just have inconclusive breast findings to help you make a decision. Also, screening patients with dense breast tissue has shown benefit for patients that are lifetime risk less than 20%. Right now, that's not yet FDA approved, but it can be used off-label. So CM is contraindicated in patients with severe renal impairment. So iodinated contrast, just like with CT, you'd have the same restrictions. So if they have severe renal impairment, they can't get a CM exam. If they have a moderate to severe iodine allergy, CM would also be contraindicated. So now let's look at how CM compares to other modalities. So when you look at CM compared to mammo, to screening mammography and tomosynthesis, we see enhanced lesion detection. The TOCUM trial was a prospective study looking at how tomosynthesis versus tomosynthesis plus CM performed. And what they saw was a 7.1 incremental cancer detection rate increase in their first year. And then in year 2, there continued to be that incremental increased cancer detection rate of 3.8. We also see improved sensitivity for breast cancer among patients with dense breast tissue. So this is another prospective study where they looked at patients who were getting 2D, they were getting tomosynthesis, a synthetic 2D, and then after that they would get CEM. They saw with CM, they had a sensitivity of 96.5%. That's higher than tomosynthesis at 82.8% in this study. And you see that the specificity was similar. CEM is currently just a software add-on if you have a recent mammography unit. So if you have an older unit, you can't do an add-on, but if you have one of the more recent units, which you would have, it's just an add-on to the current units. You don't need to purchase a big new piece of equipment, but you do need a power injector for contrast administration, just like you have a power injector for CT. We also have the CMIS trial that's currently underway, and that will hopefully be very informative. That's a prospective study evaluating how tomosynthesis performs compared to CEM for patients undergoing breast cancer screening that have dense breast tissue. So here's an example of a 64-year-old female presenting for evaluation of extended disease. They have a recent diagnosis of ILC and LCIS in the left breast. So at both sites where the biopsy clips are. So you can't see the second biopsy clip on the CC view here because it was too far posterior in the patient to be positioned to get it in the field of view. And when you look at the CM, it's much easier to see all these little satellite findings than with the 2D mammogram. So now how does it perform compared to ultrasound? So first, the screening setting. So right now, screening ultrasound is offered for women with dense breast tissue as a supplemental screening test. CEM may be considered for this purpose, but that's currently not FDA approved while screening ultrasound is. Okay. CEM is in terms of performing the actual test, it might take a similar amount of time, but in terms of interpreting it, it's much faster. Also, if you look at the cost of the two studies, CM may be cheaper. Also, when you look at CM versus ultrasound, you can see improved sensitivity in the diagnostic setting. So a prospective study of symptomatic patients with dense breast tissue, they looked at how CEM compared tomosynthesis plus ultrasound. And here we see a 96.5% sensitivity, CEM compared to 88.5% with tomo plus ultrasound performs better. And then we also see here that the specificity was very similar. So here's a 74-year-old female who came in for an asymptomatic screening mammogram. These little circles are mole markers on the breast. The dash line is just a scar marker from probably a dialysis or such. So this patient, her mammogram was read as negative, and she came in 1 month later for an automated whole breast ultrasound exam. And here you can see a very small finding on I'm showing you the coronal and axial views, so a very tiny mass. So one thing about screening breast ultrasound, that if we see a finding, we call this patient back. We call them back for a diagnostic ultrasound, which is very frustrating for the patient. So they have a screening ultrasound because it's automated whole breast. It's just a screening test. We don't have any vascular assessment, so they have to come back for a diagnostic ultrasound. Here you can see that mass, that tiny mass on the screening ultrasound better here. It looks concerning. Patient underwent ultrasound guided biopsy, and this was an invasive ductal carcinoma. The patient then had a CEM exam to evaluate extent of disease. They could not undergo breast MRI. Unfortunately, in this case, the patient declined right breast imaging. And so she was an elderly patient and just chose not to have imaging of the right breast and couldn't have the right. So this here we can see the mass is identified on CEM it has a clip in it, but you can see the amount of background enhancement. So this is a moderate amount of background, and this is extremely limiting for the evaluation. So this is really cautionary in terms of making sure that when you perform a CEM exam, to make sure you do it bilaterally. So this is really challenging. What do you tell the patient? Do we think that all of these things in her left breast are cancer, or does she just have a tiny cancer? You know what's likely. So I thought it was all background. Fortunately, that was right. But she understood that there was a risk that it might not be. But if it wasn't, she was going to have to go for a mastectomy. So she had a left lumpectomy. Unfortunately, it was just it wound up being a 0.8 centimeter IDC and DCIS with negative margins. And that small piece of tissue is the size of the clip. Sure. Okay. So how does CEM compare to breast MRI? So when you look at diagnostic performance, a pool meta-analysis found that MRI did perform better with a sensitivity of 97% versus 91% for CEM. While CEM in this study had better specificity, 74 versus 69%. When it comes to breast cancer staging and evaluating treatment response, they were comparable, the comparable sensitivity. And I'll be really interested to see, I know you're studying that here, with extended to see the Fuji units. So I look forward to seeing more data on. And then cost. CM is obviously dramatically less expensive. There's this issue of workflow and access. So a CM exam, the actual exam, once you've injecting the contrast and imaging, takes about 10 to 15 minutes. And if you look at just time on the scanner for an MRI, it's about 30 minutes for an MRI, depending if you're doing extra research sequences and such. But a standard MRI is about 30 minutes, maybe up to 45. And we just have such a limited availability of MRI and competition with other modalities. Neural brain MRIs are always going to take precedent over MRI. It's hard to have that time on the scanner. The nice thing about CM is it's done on your mammo unit. That's only for breast imaging. So it's contained with the breast division. What are the limitations compared to MRI? Well, CM data is clearly less robust. It's a newer technology. While it's been around since 2011, not that many places had implemented it at that time, and it's been ramping up. It provides much less imaging detail, right? So looking at margins of these masses or the shape of these masses is pretty challenging on CEM. You don't have any of that 3D detail, and you don't have any kinetic information. So right now, for example, findings that you call BI-RADS 3 on MRI, you check the T2 enhancement, you check, is it oval circumscribed, how are the kinetics? We don't have any of that information for CM yet. And there is work being done on kinetics of CM. Also, you have a different field of view. So the axilla and posterior tissues are not fully included. So if you have a far posterior cancer, it's not right. You should definitely do a breast MRI for some disease. And then also there's this question about iodinated contrast. So the risk of contrast reaction is about 7 times higher than the risk of contrast reaction with gadolinium. And so that definitely is a consideration as well. So any patient with a lifetime risk of percent is therefore recommended to get a breast MRI to assess their findings, and also anyone with the findings in the posterior breast. Okay. So here's a patient. I just want to show you the difference in field of view that you're looking at with CEM compared to MRI. And so here's that CEM exam I showed you earlier, and the patient had MRI for extended disease. And here I'm just showing you the MIP images. So of course we can obtain a MIP. We can see a lot more detail, but you see how much of the axilla and chest wall we include with our MRIs. And so obviously you can't do that. We'll see. So now let's talk about implementing CEM into the clinical practice. The CEM and tomosynthesis were both FDA approved in 2011. So why is CEM only taking off now, whereas everyone has tomosynthesis, right? So, not enough data. CEM biopsy only became FDA approved in 2020. So if you didn't have a way to sample findings from CEM, it's hard to take on CEM. It was only approved by the FDA for diagnostic exams, so that really limits the number of patients if you're not going to do it in a screening setting. Risk associated with iodinated contrast, especially if you're in a setting where you don't have access to a rapid response team or techs familiar with using IVs, placing IVs. And then also there wasn't guidance in terms of management. The BI-RADS lexicon for CEM came out recently in 2022. And so without guidance, it also becomes really challenging to take on a new modality, right? So for these reasons, I did study through the Patient Care and Delivery Committee with the Society of Breast Imaging. And what we did is we set up focus groups comprised of participants serving as lead on implementing CEM in the practice to identify barriers and strategies for successful adoption. And this is just out now if you want to look back at more of the data from it. So this was an email invitation through SBI Connect portal. And we invited all breast radiologists that had implemented CEM recently to participate. And we collected survey data from them to assess eligibility and gather demographic information. Why is this helpful? I think this is really telling because you want to know before you take on a modality, you want to know what you should expect. Like how are other practices doing? What's my 1 year mark, 2 year mark, 5 year mark? What sort of volumes are you expecting? So when we look at all 43 respondents, you see the CMs performed per month. So you see the vast majority were performing less than 30 CMs per month. Basically, no one was performing over 30 CMs per month unless they were past the 2-year mark. So within the first 2 years, you won't, it's really hard to get above that number. And then when we look at those people that are performing 120 CM exams per month, so all those groups had implemented CM more than 5 years ago. So when we looked at the respondents, there was a large number of international respondents, 35%. So only the respondents located within the US were invited for these focus groups, just because of the billing practices and how CM is used. You can see that CM was really taking off internationally, and that's probably because of the limited availability of MRI in other settings, right? And cost. So participants were invited that were from the US, and then we led 2 focus groups, and with a qualitative researcher, we had an interview guide, and I'll include some of the findings as I talk to you about the process of implementing CEM. So there's only 10 participants from different sites across the United States, but these are participants in both academic and the private sector and community. They varied in the years since implementation, and they're located within the US, and also in terms of the volume of studies that they were interpreting per month. So from these focus groups, major challenges to implementation can be divided into 4 major: patient selection, contrast, billing, and workflow. So I'm going to walk you through each of these. So first thing to say, for a program, you have to decide who are you going to offer CEM to. So we talked about the screening application. So everyone in these focus groups initially started with just patients that had a contraindication to MRI. The safest group, contraindication, or really they couldn't do it for claustrophobia or other issues. That's a very, very limiting number of patients. The groups that had high volumes were looking at for non-high risk patients for screening if they had dense tissue. And diagnostic application. Some groups were incorporating CM right into the diagnostic workflow, meaning you have a patient with dense breast tissue, you call them back for an asymmetry or an architectural distortion. When they come back at dense tissue, they're immediately doing a CM exam instead of the regular mammogram. The convenient part about that is if you're billing it already, a CM is billed as a diagnostic mammogram, so the patient's getting more for the same cost, right? And so these practices that were performing CM right away for every diagnostic recall with dense breast also had much higher volume. And then most groups are using it for extent of disease or treatment response. Another interesting use is patients that are coming in for same-day staging. So if you're at an academic institution with a lot of outside referrals, you have patients traveling pretty far for your care. If they're coming to see a breast surgeon, it may be challenging to get them in last minute on an MRI, but they may be able to get that CEM and it evaluated and read before or in between their appointments. So that's really useful. And some practice for doing that. So this is our current recommendations at Stanford, what we're using. So, obviously annual mammography with tomosynthesis is what we usually perform. And so for patients that are not dense and they are average risk, we don't recommend supplemental screening. For patients with dense breast, or if they have intermediate risk, then we offer them CEM. And so the interesting thing about CEM is if someone's coming in for mammogram and ultrasound, they would just come in and get that CM exam once a year. And we don't have an abbreviated MRI option right now. So the other option is obviously an MRI, but that's extremely costly. And so we are offering ABIS as well. And what we find is that our ABIS is more expensive than the CEM exam, since we're billing it as a diagnostic exam. Then for patients with any density that are high risk, we recommend they get an MRI, and only we recommend CM in the cases in the instance that they can't have an MRI or there's a strong preference. And then, the interesting thing here is for patients that before couldn't have an MRI because they had this contraindication, they would be getting mammogram plus ultrasound. But with CEM, it's just a single visit. Okay, so when it comes to contrast planning, this is always a major challenge. Participants in these focus groups discuss how concerning it was to not have a code team available. You know, you're at a site other than the main hospital, you need a rapid response. How long is it going to take them to get there? Who's going to be managing that? And that's going to be you and your staff, right? And so while as physicians, most of us have been trained in contrast reactions, especially if we read CPR in a facility that does, most of the support staff are not familiar with this. So this can be really scary. It does require some preparatory work. So there's a few things that have to change in terms of your workflow, right? So patients have to be screened for their renal function, ideally in advance. And you can incorporate this into your EMR or have nurses that do that. Also, they need to be screened for the contrast reaction history. So when patients come in, if they don't have recent lab values available, how are you going to do it? So if you have point of care testing, that's ideal. Sending labs doesn't work. It just takes too long. For reaction management, you just need a standardized protocol, which you should already have with your CT scanners, but that needs to be moved over to the mammography section. And then informational handouts, so in an emergency, everyone knows what they're doing. Most people do mock training drills to just get people more comfortable, get crash carts for the breast section, make them easily accessible, make sure everyone knows how to use it and where to find things in case there is a real emergency. And while, you know, the concern of contrast is real with iodinated contrast, a pooled analysis of 84 studies, including 14,012 patients that had CM, found that there are only 30 adverse reactions in total. So that is 0.82% of patients. And so the vast majority are very mild reactions. But there was one severe reaction, and these reactions can be life-threatening. So the likelihood of a severe reaction was 0.007%. Okay, so it's a real risk, but extremely rare. So next, billing. So billing is a challenge because there's no dedicated CPT code. So you can't bill someone for a screening exam. You have to bill them for a diagnostic exam. And this is a challenge. Some places, when we looked at these focus groups, this was a major barrier. They could not perform screening CM in their practice or decided not to. And they just left it to only the diagnostic setting. So some places are doing that. Others are using it for everything. And then this can be a challenge also walking through the institutional compliance and how you're going to recoup costs. So when we look at the ICD-10 codes that we're using at Stanford, this is what we're using, these 3 codes: encounter for mammogram for malignant neoplasm of breast, mammography density found on imaging of breast, or family history of malignant neoplasm of breast. Those are the 3 most common codes. Often people have more than one code. But we actually haven't had any claims denied so far. And what we do is we bill for the diagnostic mammogram, and then we bill separately for the contrast. And right now, even also the contrast has been covered. And then if the contrast isn't covered, we don't usually bill. So that's how we kind of decided to manage. Otherwise, it would be more. So the next step is really determining the appropriate workflow for CM. You know, it's a logistical challenge that often, however you set up your program, you're going to modify it based on what your availability is and staff. So a significant amount of preparatory work is really needed with IT to create order sets. It sounds like you're using Epic now, so within Epic, and to enable appropriate scheduling. So you need both IT for the scheduling and the order sets. Hopefully you can have a screening set in there so that can help you with the contrast screening in advance. Next, you need to figure out IV placement, particularly who is going to place these IVs and where they're going to place the IVs. So if you use experienced IV tech, that's going to be much better than using someone new that's going to take a longer time. If you're having trouble with access to veins, it's important to get a vein finder per your unit. And then also just have a backup. So most places find that you really need to place IVs in a separate room. Otherwise, you're going to tie up the mammography. And you need to plan, you know, who's going to be there for the CEM exam. Most places start initially with 2 techs to allow for training of the second tech. But once programs are up and running, a lot of places switch from having 1 technologist and 8. And then next you have to figure out interpreting and reporting. That's made a lot easier more recently with our new supplement to the BioRes lexicon, and how you're going to manage the findings. Okay. So we talked mostly about this already. Just looking to see if anything I'm missing. So the only thing to emphasize here was that for high volumes, it's really important to have a separate location for where you're placing the IVs. And then what you're going to do for billing here, whether it's diagnostic mammo or diagnostic mammo plus contrast. So I'm performing the CM. So once the patient enters the room and they already have, in our case, they already have their IV placed before they enter the mammography suite. So they're set in like a patient waiting area in advance. Then they get their injection of contrast, and then there's a 2-minute wait before you move the patient out of position. After you move the patient and you can start positioning, you have to obtain all the images within 10 minutes. So it's very important at that point that you expedite image review of these cases. So you could have them done in batch and run later, but what we do, since we're billing them for a diagnostic mammogram, if they have calcifications or something else that needs to be worked out with mammography, we don't want them coming back for a separate test. So we do any immediate imaging from mammograms right then and there, okay? So the tech will message us and say, you know, new CM case, we'll look at it right away and see if we need extra views. I'll show you an example of why that's important. And then you need to monitor your patients for reactions. So here's a patient that came in for asymptomatic screening. It might be hard to see here, but there's these little like white dots on the exam in her right breast. And it also is on the MLO view, but it didn't quite look like normal enhancement. It looks like maybe it was an artifact. So this is an example of just when the technologist injected the contrast, they probably didn't change the blood clots and just position the patient. So you have them go back, like that area on the breast. So it's very important to change gloves after administering, and then it goes away, right? But this case also just shows something nice that you see with MRI. So here you see a non-enhancing finding with peripheral rim enhancement. So this, we could look, and the patient had a prior ultrasound natural assist. So this is how this also look on CM. It's kind of nice that you see that nice peripheral rim enhancement as this patient had a benign exam. So after the exam is performed, you need to figure out how you're going to interpret the study. So now we do have this CEM supplement. And then how are you going to work up your findings on CEM? 31% of CM findings in asymptomatic patients without a low energy correlate have a correlate on ultrasound. But that's not all of them. So what are you going to do if you have a patient that doesn't have a correlate on ultrasound or mammogram? How are you going to manage those biopsies? So here's our workflow. So patient comes in, they get a CEM. If we think an ultrasound correlate is unlikely, we schedule them for a CEM biopsy. If a patient has a finding that's a mass or it's greater than 1.5 centimeters NME, it can vary a little bit by physician, this isn't a hard cutoff, then they'll get an ultrasound. So if they have no correlate on ultrasound, they'll go back to CEM biopsy. And if they have a correlate on ultrasound, they'll obviously go to ultrasound biopsy and post-biopsy mammogram. So the challenge here is if you don't have CEM biopsy capability, then you have to consider, well, are you going to try and use landmarks for stereotactic biopsy, or are you going to have the patient get an MRI and then come back for an MRI biopsy, because you're usually not going to do those. So that can be a little bit complicated. Here's an example. A patient was recently diagnosed with right breast cancer. She came in for extent of disease evaluation. So you can see a speculated mass in the upper outer right breast with 2 associated biopsy clips. And then here's the mammogram you're looking at on the left breast, and here's the CEM. So you can see that there's this 1 centimeter mass. So this patient went to targeted ultrasound. So they were given a virus 4, they went to ultrasound. And here you can see that irregular mass of ultrasound containing vascularity. The patient went on to ultrasound guided biopsy, and this was an invasive ductal carcinoma. Here's another patient. They had an asymptomatic, they were coming in for asymptomatic screen. You can see they have very dense breast tissue. On the CEM, and we were talking about this at our dinner the other day, what do you do with these little ditzels? What do you do with these tiny findings? So when there's one finding that you see and you don't see anything else, you have to biopsy. So this little tiny 0.4 centimeter mass was identified. We didn't anticipate that we would see an ultrasound correlate for this, obviously. So this went to CEM biopsy. Here we are using a lateral arm approach. Now, for these small findings, the challenge is really the size of the breast. So with stereotactic biopsy, you have this little window that you're looking at for your biopsy, but we have to get the exam under 10 minutes. So if you're going to take a lot of time repositioning your patient, that may present a problem because the contrast is not a washout, right? I find that so far with CEM guided biopsy, I make sure that the tech, I'm much more on top of where the tech is positioning the patient to make sure I think that they're well positioned with the nipple and profile exactly how I want it, and that is where I think it's going to be really useful. And then you have to be pretty decisive. This finding still is pretty subtle. But you can see it here. And so far, we haven't had any challenges doing the actual biopsies, but it does take a minute because if you're, if you want to run back in your room to go look at your own monitors and see if you can see it clearly. I know sometimes if there's really amorphous calcs and you're unsure if you're in the right spot, we might do that. You don't want to really be wasting that much time because then you won't have any more contrast enhancement. So you sample the finding, and then of course, once you sample the finding, you can't check if you have you don't have a means of checking the sample to see if you have an enhancing mass within it. So you sample the finding. We do post-biopsy mammograms on all of our post-biopsy specimen radiographs for all of our patients. But you have no way of checking whether you actually got the finding. So we place the clip and then just get our standard post-biopsy views. We always get a post-biopsy tomo on all of our patients just to confirm positioning. So you just have to trust that you're in the right spot. And so far, this has worked really well. But of course, I'm sure we'll encounter challenges eventually. Here's another patient. This patient had a recently diagnosed right breast cancer, and we were looking for extent of disease. You can see the mass in the right breast that's containing a clip here, okay? Here's their CEM exam, and I hope you can see here, it might be a little bit too much lighting, but you can see, now this is challenging, right? Because now we have 3 findings. So what do? Well, because she has cancer in the right breast, you're much more concerned. And then for us, we really don't want them to have to go to surgery for a finding that, and then have to go back for the other breast. So usually we work these ones up. It's really hard. So you could go to ultrasound if it looked totally bad on the left. So you could be like, oh, maybe it's a BI-RADS 3, but how do you manage that with CM? In this case, we went to ultrasound. We were able to find correlates on the left. Both were biopsied under ultrasound, and those were fibroadenomas. And then that one on the right went on to CEM biopsy, and that was DCIS. And sorry, I should have explained that when you're doing a CEM biopsy, it's the same thing as how you'd biopsy an asymmetry with 2 views. So you don't have tomo, right? So it's, you have your 2 views where you're putting your little hash, and you can either do it a scout and then one of your pairs. So it's just a little bit different. And everyone knows that those biopsying asymmetries and are challenging. So this patient had neoadjuvant treatment. This is a great opportunity to see how the CM compared after treatment. So you can see on the mammogram, it's hard to see if there's still mass there or not, right? It looks like there's kind of dense tissue in that area. When you look at the CM, I don't see any more enhancement. And then just to show you pre-treatment CM and post-treatment CEM, so the patient looks great. Okay, so in terms of implementing CM, the highlights, so you have to define your eligible patients. You need to incorporate CM into the screening and diagnostic workflow. You need ordering and scheduling to be put into the EMR. You need to have some process for screening for contrast reactions or have nurses pre-screen patients. You need point of care testing. You need an experienced IV staff to place IVs and a separate IV insertion room, and to develop protocols for contrast reactions, and then establish billing procedures and determine anticipated patient costs. So I think determining how much it's going to cost the patient. So if a patient's coming in for a screening mammogram, it's free, insurance covers it. For a diagnostic CM exam, most patients have some sort of out-of-pocket cost, and that might be a few $100s. And so not everyone will feel that that's a reasonable. So other uses. So I showed you our current protocol for CEM, but I think the interesting thing about CEM is there's so much opportunity to use it in different ways than before. So one thing that I'm looking at right now, I'm starting a prospective study to take patients where you see something suspicious on the MRI and you need an MR biopsy. Now, our wait time on MR biopsy is often 5 to 6 weeks. Your patients might already even have their surgery scheduled and they can't get in for their MR biopsy. So one thing we might be able to do is to take patients and assume that they don't have a correlate on ultrasound. If they have a correlate on ultrasound, they do an ultrasound biopsy. But if they don't have a correlate on ultrasound, well, can they go to CM biopsy instead of MRI? And I think that might be a great way to, decrease patient costs, improve patient comfort, and unburden our MR scanners. Thank you so much. I know that was a little bit of a whirlwind. I'd be happy to answer questions if there's.
Here's bilateral CBM biopsy. They would need to be done on different days.
Yes, so because when you give you could try, but the problem is that 10-minute mark, right? So yeah, so we don't do bilateral CBM on different days. And that prospective study where I'm gonna incorporate it, one thing one of the restrictions is they have to have a single site because you can't biopsy. You know, normally you say they have multiple findings in the breast. You know, if you're doing an MRI, you could biopsy
Simultaneously.
three. Sometimes we'll have a 3-site MR biopsy. Blows my mind. But when you can't do like that with CM, so you would do just one site at a time. So even 2 sites in one breast might be really challenging. You might be able to do it, but I think people would be a little bit unsure if it was going to be successful or not.
Yeah, maybe if you've been doing it for 2 years and you have a tech who is really experienced.
Yeah, it's like having the right tech. You know, you have your golden tech that's like very fast on the ball. You might be able to do everything, but yeah, I think but bilateral do on the same day. So that's hopefully you don't have that many. And we have some, not a ton, but we do have some. Other questions?
Sorry, I'm new already on this. I'm totally clueless about contrast enhanced mammography, but subtracted images.
Well, they say it's a process.
Almost like everything was subtracted.
Yeah, they're processed.
Oh,
So it is, we call it a subtracted image, but it's a processed image. And so on the unit, that's immediately obtained on the imaging unit that you use. But both images are actually obtained in succession after administration. So, you know, it's the difference between when the contrast enters that tissue and what area is taking up the tissue. So you're really looking what's taking up contrast versus not.
I see. So the breast cancer is very enhanced rapidly.
So yeah, usually in under 2 minutes.
So is any false positive, any other benign lesion that has a similar hemodynamics?
So that's a huge problem, right? So with MRI, we're able to say something is probably a fibroadenoma, probably benign when you're looking at MRI. So maybe you see something and it's oval and it has either persistent or plateau kinetics, and you say, okay, I can BI-RADS 3 that. We don't have that imaging data with CEM. There is research being done right now on obtaining delayed CEM images to see if we can use that for better guidance, but it's hard because we lose that kinetic information.
I see. And how much contrast are you injecting?
The same, it's weight based, just like CT. So the same amount you get for like a body CT. So it's a lot of contrast. That's why you have to use a power injector. I think during the pandemic, a lot of people couldn't get power injectors. There was a huge back order, and so people were trying, and then that's just not feasible when you have a big syringe. Yeah.
I see. Well, I think based on the MRI manual and the ACR, if you don't have any kidney disease, you don't need to do creatinine check.
Well, it's obviously institution based, but if you have any medical problems or are above a certain age, then we do check the creatinine because it's nephrotoxic. Also, if it depends what your use case is too, right? So you may have different restrictions for diagnostic patients versus screening patients, right? So if how comfortable are you giving a screening case for toxic agent as a screening test, and so I think that people have to think about. We have the same protocol for everyone, and we just use the same exact protocol that we have for our CT scanners.
So 40, 50 years old patient with no kidney
problems, they don't have diabetes. Yeah, but what you'll find is when you start looking at your patients that are 60s and 70s, everyone has something. So you have to have like an I-stat. So you have to have and that's easy, but it's just something that you have to buy in advance so that you can check your creatinine on the fly, right? Anyone with cancer, you're going to want to, you're going to check it too. So yeah, so most patients we do wind up having to do, except for our very young patients. Yeah.
Got it.
Another question on the low dose images, how well are calcifications shown on the low energy? Sorry.
Oh, it's just like a 2D mammogram.
So you feel like you are not missing out.
Oh, no,
if you were not doing.
No, it's totally fine. Yeah. Actually, there is data on that I can send to you. I didn't put it in my slide on what was missed. There was a study where they looked at just that processed image, and what they do, on the processed image, they're not going to see calculus, right? So you're only going to see it on that initial image, but it's comparable to others.
So do you get like mag views delayed after because you don't really get shown?
That's what we do. So tech calls me and says, hey, I just finished a case. I look at it and I see some calcs. Well, You can still get your regular diagnostic imaging. You're just not going to see that the subtraction and the imaging looks
Which
fine.
you don't need, okay.
Yeah. So the imaging looks fine. You see the calcs work amongst. But we really want to do that because we don't want to run into the problem that we have with screening ultrasound where they come back because it's automated. They come back and then they get their diagnostic ultrasound. So we don't want to bill them twice for a diagnostic mammo.
The logistics of, do you do for your callbacks?
No, we don't yet.
Okay, because I was gonna say logistically, that seems hard to know who to do that on.
So the groups that are doing that, what they're doing it is if the patient has dense breast tissue, yeah, they do it. And the participant in that focus group, they were doing 16 CMs a day. They're doing a lot of CEM. So they really had a high volume practice. The interesting thing is the people that have like a really robust volume of CMs, they started CEM when it was still in the research setting. And so if you're an early adopter, you didn't even have CM biopsy at that time. So some people are very comfortable with CM now and using it in that sort of setting. It's also interesting because while we use BI-RADS as if it's as a diagnostic exam, not everyone's doing that. That's just talking to my colleagues at Sloan Kettering. And while they used to do that, they switched to using BI-RADS 0 actually for their CEMs, treating it as like a callback. It depends on your setting and what resources are around. I don't know if that is dependent on which location they're reading to. But there's still a lot of wiggle room. Yeah, determining how you're going to work things up and what you're going to do. And there's a few different ways of doing things.
Okay. Thank you.
Thank you all so much. And I'm going to give a case conference right after this.
Yeah, and I think
In a few minutes.
our third names are all right here. Back row and right here.
Oh. It's so nice to see you. Aren't the boards on Monday?
Wednesday.
Oh, Wednesday. Oh, great. Oh, I think it will be really helpful. I didn't want it helps me like complicating effort here, but we like very elaborate recipes all.
I forgot to.
Well, so I know, and they're not.
No, it's right.
It's your.